Hi, good morning, everyone. Good evening, and I would not say good night, but good late evening for members joining in from US. We always have people from different time zones. Welcome to 96th edition. We have been there for last almost couple of years on this platform, sharing important discussions on the pandemic. We have seen a lot of new variants coming in, and whatever the knowledge is being shared gets distributed from doctors to the international platform, to the general public. And I believe a lot of help is happening, an initiative by Dr. K.K. Agarwal a couple of years ago. So here we are on the 96th edition. And today we have a special last minute presentation from Dr. Monica Vasudev. And we then post that presentation, we will have some new members in this group and an update from the countries on COVID. Monica, would you like to just share your presentation first? So we have Dr. Monica Vasudev from USA. She's been a regular attendees over here. Yeah, you can share the screen, sorry.
Sure. Thank you, Saurabh, and thank you to everyone that's here today to share your time. I know we have a lot of things going on and we're at different stages of the surge in our own regions. And this is such a fantastic way to hear about things, about other experiences and ways to approach current issues. I'm joining the meeting after several weeks. As you had heard, our grandmother passed away this past weekend, and it was in her memory that we are celebrating her and how she really focused on educating all of us, and mostly our uncle, Dr. K.K. Agarwal, that had started this forum. What I want to do today is talk about just a few updates that I think are very critical in terms of what's happened in the past week in the United States, as well as to review some of the emergency use authorizations for the treatments of COVID in the outpatient setting. There's been a lot of conversations, at least since I've been giving these presentations about the vaccines. I'll give a few words about the vaccines, but I also wanted to broaden the discussion to about medications that are now available. So as I share my screen. So this is so timely information. It is rapidly changing. As I present, there might be additional updates that are being released. And I apologize if this is not the most up to date, but as you can see, this is the information that I am presenting today. So I'd like to start off with the Omicron variant, BA.2, which is also known as the stealth variant. It was first detected in genome sequences from the Philippines in November of 2021. It is found in 49 countries. It shares many of the same mutations as its ancestor strain, which is the original Omicron, but with a further 28 mutations that have not been previously seen in the Omicron variant. One of the mutations that was seen in the original Omicron variant was easy for it to be detected and typed, which is not found in this new stealth variant. But what we know is that this is the dominant strain in Denmark, as you are aware, but right now in the United States, from at least the data that I've been able to see, is that we're still 99% or more of the BA.1 variant. This BA.2 may be more transmissible, but there's no evidence that it has been associated with more severe disease. And we see that those who are vaccinated and boosted, just like it is better, it provides better protection against the original ancestral variant, that I felt the same as felt about the stealth variant too. New information that is new and critical in this past week is that on February 1st, Pfizer BioNTech asked the FDA to clear the 2 vaccine dose regimen for young children to start. And this is the screenshot from the New York Times. Children 2 to 4 years of age who were given 2 shots were infected at a rate of 50% lower than the children in the placebo group. And in the 6 months to 2 years old who got the shots, a little bit less in terms of its efficacy, and they were able to have a reduction of 50% of infection compared to the placebo group. Another piece of news from this week was regarding the Novavax. I had presented data earlier in June regarding their initial data and its efficacy also against the Delta variant at that time. That was data that I had shown to you from the United States and Mexico. This is data that was presented or found in the New England Journal of Medicine that was published. It looked at 14,000 participants in a randomized placebo-controlled observer blinded study, which I believe was from the UK. They found that Novavax had an overall efficacy of 89.7%. The primary endpoint was based on the first occurrence of PCR-confirmed symptomatic, which is mild, moderate, or severe COVID-19 disease with onset at least 7 days after the second study vaccination in serologically negative adult patients at baseline. And what you're seeing are the reduction in infections in those who've received Novavax, which is seen in the rust-colored line, compared to the blue line that had received placebo over time since either the first dose, since the start of the observation period, with the variant of concern as some of these diagrams. And all these diagrams are showing similar trends. This new vaccine has a subunit protein platform. This vaccine is formulated with an adjuvant to enhance immune response and stimulate high levels of neutralizing antibodies. Adjuvants are specifically meant for immune stimulation. The technology is the same as that's used for one of our seasonal influenza immunizations called Flublok. And it's similar to other vaccines that have been around for quite some time, like the hepatitis B vaccine. And that's very important when we're addressing those individuals who have been vaccine hesitant. On February 3rd, we had the conditional marketing authorization by the Medicines and Healthcare Products Regulatory Agency, the MHRA in the UK, and it's also received approval in Australia that Dr. D'Souza can speak about as well. So we're really looking forward towards the potential approval of Novavax from the FDA, either through EUA or full approval. What was reported here by Dr. Pelletier on January 28th, it was reported on MedPage today, as you can see here, is that Dr. Pelletier said, this is a traditional option that's available for both the immunologically naive and those who are hesitant to get boosted. It might provide a path forward for some who are pro-vaccine, but who drew the line at the novel mRNA products. Why is this important? This is a screenshot from the New York Times on February the 2nd. And what you're seeing here is that the US is leading in deaths and falling behind in vaccinations and booster. In the top left panel, you're seeing the cumulative deaths per capita throughout the pandemic. And you can see that the US in the black line has the largest or highest cumulative deaths per capita. Then you're looking on the panel on the top right corner, showing the cumulative deaths per capita during the Omicron wave, and you're seeing a similar trajectory here, except the US is much, much higher. We're looking at the bottom left panel where it says the share of the population that's fully vaccinated, and you're seeing that the US is much lower than other large high-income countries. And then in the bottom right panel, you're seeing that the share of the population that's received the booster dose, and again, this is quite low. So hopefully the Novavax can address this issue. I mentioned the panel about the booster dose and why is the booster dose important? And this is a shot from the CDC. And what we know is that people who are unvaccinated and had a greater risk of testing positive for COVID-19 and at a higher risk from dying of COVID-19 than those who were fully vaccinated. We also know that people who were fully vaccinated with an additional or booster dose had lower case rates than those who did not have that. And what you see on the graph on the right side is the black line that is the unvaccinated, and then you're looking at the incidence per 100,000 population on the y-axis. I selected just for this photograph the cases. I could have chosen cases or deaths, but the graphs are pretty similar. And in the x-axis going across, you're seeing time of October 2021, November 2021, and December 2021. And as we know that the Omicron variant was first detected around Thanksgiving in the United States and then started to increase, we're seeing that the incidence of the cases had increased markedly in the month of December. And look at the difference between those who are vaccinated in the black line versus those who are fully vaccinated without the booster dose in the dotted blue line versus those who are fully vaccinated with the booster dose in the solid blue line, with those who are fully vaccinated having the least incidence per 100,000 population. What we're seeing at the bottom underneath the graph are these statistics that show that unvaccinated adults who are 18 years and older had a 13 times more risk of testing positive, having 5 times more, in December, 5 times more, and 68 times more of dying from COVID-19 in November and December compared to those who were fully vaccinated with booster doses. I'd like to move on just very quickly and talk about the COVID-19 EUA therapies. So we have in the non-hospitalized patient with mild to moderate COVID-19 who have a high risk to disease progression. This is coming from the NIH. We have Paxalivir, which is the oral tablet, the Paxalivir. We have the sotrovimab. We have the Remdesivir, which we're all familiar with, and Malnopivir. We also have, this is for people who have disease, for those who were looking for a pre-exposure prophylaxis. So people who have been identified as those who are unable to mount a sufficient immune response because they're on immune modulating therapy or they cannot get the vaccine. There is the new the EUA for Uboshield. Okay. Paxalivir, these are just going to be a series of rapid slides that just gives you a summary of these outpatient therapies. With Paxalivir, you have an 88% relative risk reduction. It's nirmatrelvir, 300 milligrams plus, which is 2 tablets. Each of those are 150 milligrams, and ritonavir, 100 milligrams twice daily within 5 days of onset of symptoms. This is approved for those who are 12 years of age and older, so it is available to our older pediatric group, and they have to be greater than 40 kilograms. This medication needs to be renally dosed, and so you can give it for those who have a reduced creatinine clearance. You can give them the 1 tablet component of the nirmatrelvir. As you can see, I'm going to go through the list of these EUA medications from those that are most recommended to those that are least. So this is the first one. The second is sotrovimab. This one has an 85% relative risk reduction. It's given 500 milligrams IV once as an infusion within 10 days of the onset of symptoms. So that really gives you the flexibility of your patients who contact you and say, oh, I'm positive. You've identified them as being appropriate for infusion, and you have a longer time period, which is like 10 days with an onset of symptoms. And it is also approved for older children, 12 years and older, and those who are 40 kilograms or more. And it is shown to have activity against the Omicron variant. Remdesivir has been around for quite some time. We are familiar with this drug. It has an 87% relative risk reduction. It's given 200 milligrams IV on the first day, but then needs 2 additional days, consecutive days, where they get 100 milligrams IV, and it's within 7 days of onset of symptoms. So these patients need 3 days of continuous therapy, 12 years and older, 40 kilograms or more. We are familiar with this. When it's used inpatient, it's been used for about 5 to 10 days, and it does not require hepatic or renal monitoring, and they have to be observed for an hour after infusion. Malnopivir, 30% relative risk reduction. It's given at a dose of 800 milligrams twice daily for 5 days. It started within 5 days of symptoms, and this is approved for adults only 18 years in age and older, and that's because of the toxicity concerns related to the bone and cartilage, It's also not recommended in pregnancy due to embryo-fetal toxicity risk, and it is less effective than the other medications that I had mentioned earlier. So now about the pre-exposure prophylaxis infusion. This is Uboshield. This is administered as 2 separate consecutive intramuscular IM injections. It is, again, meant for those as pre-exposure prophylaxis who are not expected to mount a sufficient immune response and are unable to receive COVID-19 vaccines. This is also approved for older children and 40 kilograms, not milligrams. I have used this Uboshield in my common variable immune deficiency patients, those who don't have the ability to mount good antibody levels. And thank you for your time.
Thank you, Dr. Monica, for a quick presentation. And we already have Monica for a question. You need to unmute yourself. Dr. Angelica, would you like to ask a question?
Thank you so much. Thank you so much, Monica. This is an excellent, summary of what happened. I just also want to add to the BA.2. We had a discussion this week on it, and it seems to be, maybe I'm wrong, but this is how my impression from this, from the meeting we had, is that it's much more of a academic value, whether you have B1 or BA.2, because clinically there's not really a difference, and the outcomes of the patients, as you correctly said, it's not more severe, it's still mild. I was also wondering about, the difference, the clinical difference of that subvariant, whether that is because some of the patients in the beginning, or mostly the patients, were the same symptoms, but lately we have started to see some people with nauseousness as well as a bit of a diarrhea, bringing it into the symptoms of the rest of the Omicron. So I thought maybe that is part of the BA.2, but I'm not sure. But clinically, it doesn't really make a difference, and the treatment doesn't really make a difference. So this is, I think, more of a scientifically value and not so much of a clinical, the clinical picture that we are seeing. Then my other thing is, and I know it's against what all the literature is saying and all the scientists are saying, but what we have seen, and this is my experience as well with Omicron, I'm coming back to the glucocorticoids. What we have seen is in Delta, around about day 6, 7, 8 upwards, it actually played a role. Remember, in South Africa, we don't have all these nice novel new drugs. We really have, I'm always saying, only common sense that you can actually use. And so when Omicron started, we did it a bit differently. And what I have noticed, and again, this is where it is totally against what any literature will say to you. If you see your Omicron patient today, and you start with very low doses of cortisone, we don't see any comebacks. It's very, very interesting. Those that didn't start on it will come back and only get better the moment we put them on a low doses of cortisone. And it goes against what everyone is saying, but this is what we are experiencing, and maybe at some stage we need to write it up or do a a clinical study on this in connection with these kind of drugs, or these kind of COVID and Omicron and the difference between the different variants. But thank you so much. Unfortunately, all those nice drugs that's out there, and I love that last one for people who can't take vaccines or got a, and they can put that proof of pre-exposure type of vaccine. I think there's a lot of value. But in South Africa, we will never get it because it's too expensive and the medical schemes won't pay and the government won't pay for it at primary healthcare level. But thank you so much. And if I can get the slide, it will help me a lot to just also look about, go to look at those articles. Thank you so much.
Yes, of course. Thank you so much for your comments. The question I have for you, okay, so in terms of our clinical experience, I'm able to get strontilimab, and I'm able to get the oral antivirals, but the Uboshield is a little bit more difficult for me to find for my patients. There is short supply, and there really is a committee that sits to evaluate whether or not our patients meet criteria. So even though it is available, it is not available to all. When you give the low dose corticosteroids, what doses is considered low? What dose are you giving of what, and how long are you treating your patients for?
Thank you, Monica. So what we have seen, okay, the children is fine because most of the children don't really get sick, and so not most. Well, I can't remember since Omicron started that we haven't admitted one child, and I'm not actually aware of any of my patients' children that had been admitted without going through us. So we will normally around about the age of 12. What we will do is we will give Medrol 4 milligrams, methylprednisone 4 milligrams, TDS 5 days. That's the highest we will go. And for adults, we will go prednisone 4 milligrams. 20 milligrams twice a day, or 20, or if they can tolerate 40 milligrams once a day for 5 days. So it's very short dosages. It makes a huge difference. Maybe sometimes just try it and see whether we are wrong. But it really, we don't have comebacks. There's not even 5 days. After they finish their course, we don't see them. There's no long-term side effects, nothing. It is totally against what the literature is saying, but this is our experience, and it makes a huge difference. And those patients that didn't get it, or patients calling us from other doctors that's been sick for 2 to 3 weeks after that Omicron and only treated with antibiotics. Why the doctor still prescribe an antibiotic for Omicron, I still don't know. It's beyond me. We then put them on a 5-day course of methylprednisone, or normal prednisone for 5 days, and it's fine. They're over it. Very interesting.
Thank you. Thank you so much for that.
Monica, sorry, I just want to add one thing more. I just want to say, for the children, the small children, what we have seen, we give them what we call Tamiflu in South Africa. It's oxaltamivir, something like that. And whether it works or not, those children are also fine. So that's very interesting, because that we don't have anything else. So maybe that's a placebo. I don't know, but that's what we will give for the small children. Thanks.
Okay, so I also would like to invite a special guest today, Dr. Errol Alden. He's also a pediatrician from US. Do you want to give any update or comments on this topic, what we are talking about, or in your field?
Well, thank you for asking me to say a few words, and I wasn't aware I would be doing this, so but I really appreciated Monica's presentation. That was absolutely outstanding. We're seeing, I think, as everybody's very much aware, much increased incidence with Omicron with the children. So a couple of weeks ago, we were over 1 million cases. This last report that I have is just about 800,000. The cases are not as severe as we've seen in the past. So our intensive care beds and deaths are not as bad, but we are seeing far more children. Monica discussed where we stand as far as vaccine availability for children. We're looking forward to getting that to down the under 2 to 4 year old. Our big problem is, as she also put on the charts, is the vaccine refusal or vaccine hesitancy. That is a major problem for us. We're not nearly as high on teenagers as we should be, and the other children. So we're working very hard on that. And I know Naveen Thakur there in India is working very hard on vaccine hesitancy, and we're combining forces to try to do a bit better job and get those rates up a little bit higher. Our multiple system disease is higher than it's been in the past, and we're beginning to see some disturbing evidence that those children have long-term outcomes. It's still pretty preliminary, but that seems to be going. We're watching that very carefully. But thank you. I've enjoyed Monica's presentation and the questions, so thank you very much for including me.
Thank you. Anybody else has a question?
Yes, Sharab. I thank you, Monica. Thank you very much for excellent presentation and a lot of information. I didn't know much about BA.2. I just need few clarity. One is it a BA1, BA2, BA3? Are they a cousin brother or what? How does it reflect in the clinical situation? And the other thing is a mild infection. This BA.2 will not give enough immune response or protect to another Omicron infection. And the last one is why anti-vax group is against even oral anti-vax tablet. Is any idea? Thank you. Thank you, Monica.
Okay, so I'm just showing you that there is, I'm sorry about that. That was not where I was going with this. That there is similarities right here, as you can see on the right, on these BA1, BA2, and BA3, that the ancestral Omicron was BA1. And the deletions that have occurred in them have provided from an ancestral drift, the BA2 and BA3. I had a great diagram in an earlier presentation that showed the variations in the genetics behind the different variants. What we see so far is that the vaccinations have been effective against the variant, the Omicron variant, as it is to the ancestor Omicron. And that's if you've been boosted. In terms of infection with the original Omicron, I believe, which is your question, to whether or not it would protect you against the variant, I'm not sure. But as Dr. Kotze had said, it's a more of an academic discussion of which variant you have. There might be some slight variation in the clinical presentation. But I think the biggest thing that I had seen, at least in what is the difference, is that the Omicron ancestral, which was the BA.1, was easier to detect, and that BA2 is not necessarily as easier to detect based on the laboratory information. So I hope that answers your first question. And I don't know how to answer your second question. Dr. Hussain?
Yeah, no, second one was, I think you answer almost because if someone get BA2 or that other BA3 variant infection, will it protect from others 28 variant response. And the last one is anti-vax in the antiviral tablet. The sentiment is growing. So I understand anti-vaccine, they're frightened from injection and all the myth and theory. But now tablet is also, they are talking against it. That's my concern.
I agree. I believe that we don't have enough information to be able to answer those questions. And I do believe that the philosophical approach is to continue to not only be vaccinated, be boosted, follow the line of how we are looking at hospitalization rates and deaths in populations, in regional areas, based on what we know is what the spread is, to be able to get that information. And that should be in terms of that multi-pronged approach, where it's more than just vaccination, but it's masking and it's also hand washing. We are seeing better data and better outcomes about masking too. I didn't show you any of the newer kind of conversation that's been shown from the scientific world about those who have been wearing masks have had less infections as well. But we are seeing that, I think that especially in these highly contagious variants, that we still need to continue to make decisions that are going to reduce infection in the first place as well.
Thank you, Monica. Thank you so much.
Hands are raised.
Thanks. Suman, I just want to say, maybe I can answer Otkar's question regarding the clinical symptoms. What I think, because they don't test routinely in South Africa, that was clear this week on the meeting as well. They're not going to test whether it's the one of the Pango lines or whether it's the normal Omicron. So if I look at the clinical picture, I suspect the BA.2 patients will be the ones who have that stomach component with that we don't see with the mother, the Omicron itself. That's my suspicion. But again, we don't even treat that. If you give the cortisone, and you only can give them cortisone and they're fine. We don't even treat those type of symptoms. But this is now at the primary care level. You remember, we are seeing them coming in from the street. We don't have a lot of tests that we can do. We only have, common sense and cortisone. That's about it that we have, but it works. It works very well. So again, as Monica also said, and as I have also said, it's more of an academic value which one you have. So please don't break your head about whether there's a Pango line or not at this stage. Thanks.
Thank you, Angelique. Thank you.
Okay. Any more questions on the floor?
Yeah, Dr. Pillai.
Yeah, Dr. Pillai.
Let me thank Monica for the excellent update on Omicron. My one question is that recently there have been certain articles from America which show that after mRNA vaccines, the remnants of the vaccine remain in T cells or lymphocytes even after 1 week. Does it have any bearing on the vaccine?
That is a very good question. I actually have not heard anything about this. What I will try to do is I will try to follow up on this question of yours and try to post an answer for you following the meeting, but I have not come across this concern in any of the readings or any of the news outlets that I have been routinely following, unless somebody else has an answer to this question.
And we have seen that Omicron, although it is a mild infection, the RT-PCR positivity remains, maybe up to 10 days. And whereas even the previous one, Delta, by 7 days, it becomes negative. So in spite of being a milder infection, the RT-PCR positivity continues for 10 days or even more in most of the patients where we do it.
We don't normally and routinely test right after infection.
Yeah.
And I hear what you're saying, and I think that every variant will probably have its own pattern and dynamic of how the cases are tested after infection.
Thank you.
Yes, Angelica.
I just want to add to Monica's. It is true that we also don't, if you don't have symptoms, you don't test. If you have got symptoms and you test and the PCR is positive, you with symptoms, we accept that you are infected. And we do not encourage any other PCR follow-up testing precisely for this, because some of the patients can even up to 3 months still shed some of these viral particles, but doesn't mean that you are infected anymore. So a positive PCR without any symptoms is not indicative that you are still infected. And that makes it very difficult. And I think people doesn't always understand the value or where to use the use of the PCR. And this makes it extremely difficult for people who want to travel with a positive PCR test who's not sick. There's a dilemma around that. Thanks.
Monica, I also have a question for you. Recently, I think the US government has announced where they're giving the home test free to like at least the 2 kits. How is that successful? Like, is it working out? Like, are these test kits useful and people are doing it and they're availing it?
So what I have seen is that the date for the release of these tests were a couple of weeks ago. I know of families on the East Coast in New York State that have started to receive the kits. I ordered my kits around the same time, and I have not yet received them. I know that the home testing kits, the Binax now that have been found at our kind of neighborhood retail pharmacies, they've had increased supply from the initial shortage that had occurred during the holiday season. New Year's had fallen the weekend right before school had started in many places, and I think there was an acute rush to get these kits before school started and during the holiday season. In terms of the accuracy of the tests and use of the tests, it is found that not everybody, there was actually something that was reported in Medscape earlier this week that there was not a very good rate of people who understood how to follow the instructions regarding these home kits. All of these companies have a different set of instructions. There's a huge spreadsheet or sheet that's given to you about how to perform the test, how long you have to wait, what kind of sample you need, what solutions you need to mix in one order. Some of them are easier, some of them are not as easy. So when I do get the first kit, I will share the update of what they're actually distributing and how easy it is. And I'll follow up on that at a future meeting. Unless Dr. Alden, you've received yours in the mail.
No, I have not. We haven't received any yet. My understanding is the same as yours. We do have folks in New York, particularly, that are receiving them already.
And also the big question will come is that if this tests are coming, so are you still requiring your RT-PCR from a lab while traveling, or will this test will be enough for you guys? That will not, right?
So the traveling is all based on the country that you're going to. So if you're going from north into Canada, you need to have a negative PCR test 72 hours prior to the time of your departure. So if your flight gets delayed and you unfortunately now are 75 hours, then you will not be able to board the plane. But if you're coming from Canada to the United States, you just need a negative antigen test. anytime in the day, 1 day, calendar day prior to the day of departure. So I think that these issues of PCR versus antigen test, proctored versus unproctored test, well, obviously for the travel, you need a proctored test, that they need to be according to whatever the up-to-date travel guidelines are.
Thank you. Dr. Russell?
Thank you, Saurabh, and thank you, Monica, for a lovely overview, as always. I just wanted to ask you, with the third dose that we have, we now don't consider it a booster. That's part of the vaccine. Is that right? That's what we're told. It's 3 doses. What impact or is this having in terms of this the BA1 and BA2? Is it what's the current evidence of the information we have?
Great question. I agree with you that the 3 dose now is considered to be completely vaccinated, and that is because what you are seeing is that I believe I posted that graph in the presentation on the group, and what you see under the slide that says benefit of booster dose in that presentation is that you're seeing in the month of December, which is when we had the spread of Omicron in the United States, that you're seeing that those who are fully vaccinated with booster, which was in that dark blue line, that you end up having less infections, and that thing is also trend is also seen again in those in terms of fatality. I'm just going to share the screen again so you can see this graph again. Yeah, so this is what I'm referring to. So those who are fully vaccinated, so that is 2 doses, where fully vaccinated is defined as 2 doses, is the dotted blue, light blue line. And then you see the fully vaccinated, which is the navy blue line, solid line underneath. So in December, which is when we would have had the spread of Omicron, this is extrapolated from there, suggesting that boosting has also provided a protection against cases and positive cases against the variant. I hope that answers your question.
Yeah, yes, thank you. Thank you very much for that, Monica.
So great. I don't think there are any questions on the floor. Let's quickly move on the update. We don't have too much of time. So can I start with Dr. Angelica and Dr. Akhtar Hussain from South Africa?
Thanks. I hope Akhtar will give you the numbers. In South Africa, you know what? We carry on with our life. I'm a bit worried about patients or the people too relaxed and thinking that we are out of a pandemic. There's a common feeling because some of our very prominent scientists are saying that, you know, we should discard masks and that's not working. And I don't agree with that. There's definitely protection with the mask. So it makes it difficult if some of our scientists goes against what the advisory committee or to the minister is being advised regarding the masks. But except for the masks wearing, we have now decided since this week the schools, you know, will be fully open. There will not be a rotation. We did see, however, this past week, a slight increase in cases from schools, especially the sports. Sport day is compulsory, it seems to us, and that turns out to be super spreading type of events. So we are seeing families coming in again this past week. But again, mild disease, nothing to be alarmed with. We have also discarded the fact that if you have been in contact with someone that's positive, that you should quarantine for 10 days. We stopped that because what we have seen is people stay off work You know, some people twice a month want to quarantine for 10 days because someone has been in contact and their child has been in contact, and therefore they now need to quarantine. I call them the professional quarantiners. So we have now stopped that, and we said you have to take responsibility. You have to wear your mask, and in your working place, you have to adhere to your non-pharmaceutical measurements, and you have to get your vaccines. We also saw 2 cases of people who has been sacked from work because they didn't want to vaccinate. They took their cases to the CMAAO, but also they were dismissed, and the employers were in their rights. So this is interesting times now in South Africa, because for the first time in 2 years, the people now need to start to take responsibility and cannot hide behind, I want to quarantine because I have been in contact. So we will see how this plays out going forward. You know, lots of discussion around this, but yeah, very interesting. So let's see what happens in the South African space. Thanks.
Thank you, Angelique. Thank you for giving us opportunity. Yeah, we are very happy today, after 2 years, South African Medical Association, the board of directors will have a dinner tonight. I think it's in Pretoria, so all the directors are flying to Pretoria tonight. So after 2.5 years, I think we're going to see Angelica. Okay, the new cases in South Africa last 2 weeks is between 3,000 to 4,500 cases. In fact, last 24 hours is 2,700 and 221 deaths in last 24 hours. So far, South Africa tested 32 million and 3.1 million was positive. Our recovery rate is 95.5. The said is that the total death so till now in South Africa, 95,000. Our hospital admission came down. It's now 4,800 around South Africa, and those are the public and private hospitals, 666 hospitals. ICU admission also down. It's 404 cases was admitted last 24 hours. Only 180 was ventilated. Our positivity rate is 8.2. It was yesterday's figure. Thank you. Thank you.
Thank you, Dr. Akhtar. Can I invite Dr. Yen? Can I invite Dr. Yen from Taiwan?
Yes, Dr. Yan from Taiwan. Yeah.
Right.
Taiwan is doing well to contain the pandemic. In recent 2 months, we had a low-grade community circulation of the Omicron. Still, not very. We did not take any burden from this local community burden, because people in Taiwan just wearing a face mask, even outdoors, and we have a very good hand hygiene practice, which not only the hand hygiene, wash hands, but also alcohol dispensers, and people are wearing the alcohol sanitizers all along the way. And we had encouraged so-called touch disinfect and touch and disinfect strategy to blockade the formal transmission, which in my point is very important to stop the community circulations. So in addition to face masks to block the droplet transmission and airborne transmission, we also effectively stop the formal transmission through this strategy. In that way, Taiwan remains resilient against all kinds of invasions from Delta to Omicron, and take this opportunity. We had improved our vaccination coverage rate to approach around now it's around 80% of the booster dose coverage. Yeah.
Thank you, Dr. Yen. Can I have a quick update from Dr. Russell from Australia? Dr. Russell, you're mute.
Okay. Can you hear me now?
Yes.
Okay. Well, in Australia, we are at the moment probably reached the peak for this the Omicron infection. I think right now with the BA2 has also come, but not a few have been reported. And what's happening is the peak is we've crossed that, but there is a crisis with the elderly, and so it appears that we still are having deaths, 30, 40 deaths in each state per day. And we see that there is a crisis in the elderly homes. I think many of the staff and the elderly are not yet to get their third vaccine, and from what I last saw, 85% of the deaths are appearing to be in the 60s or 70s and above, but predominantly from the nursing homes. And so there's question of wanting the army to be brought in because they don't have staff, people are sick, and people are burnt out. And so that's the crisis at the moment. The Prime Minister is under a lot of fire, and so we are facing that type of problem. But in terms of the vaccine, well, that seems to be still good. I think over 94% for the 2 doses, and roughly, I think around 30 have already had the 3rd dose. So, and we've also had a good, with the 5 to 11 years, I think we've reached, that's also started, 11 to 15. So there's good vaccination, but the deaths, I think, are a lot coming from predominantly from the nursing homes and from the older age group, where there is a crisis in terms of staffing and so forth. That's the current situation in Australia. We still, they've reduced the need for what's quarantine and so forth to 7 days, 5 or 7 days or so. So that's the situation. And if you're, even if you what they brought for healthcare, I think if you're no symptoms and you're positive, you're asked to come back to work with your masking and so forth. That's the situation. Okay.
Can I invite Dr. Pillai from India?
Thank you. Of course, in India, we are definitely, the curve is flattening with 1.2 lakhs of cases per day. It is every day, it is almost 7% less incidents are happening. So that seems to be a good thing. Vaccination drive is going very strong. 169 crores of people, 169 crores of vaccine have been given so far. The first dose 99% and the second dose almost coming to 80 to 85%. Then 15 to 18% population, adolescents, again, the vaccination drive is going very strong, and booster dose, particularly among the high risk, definitely is picking up. So on the vaccination front, we are doing very well. Regarding management, even the Omicron is responding to monoclonal antibodies. That's what we see. And particularly when you give in the initial stage, when the saturation fall is not there, the response is definitely very good. Remdesivir still continues to be the antiviral drug that is in our protocol. Within 7 days, if the CRP is very high, Remdesivir is given for 5 days. Although it has been recognized by the drug controller, it is not in the protocol, the government recognized protocol, mainly because of availability problem and because of high side effects. Then, of course, the steroids still continues to be the sheet anchor anticoagulants, depending upon whether the ferritin is high or On the basis of the markers, so these drugs are also being given. But the ICU admission, the hospital itself has come down to 6% of the total patient. And ICU admission is less than 1%. So that way, it continues to be a mild infection. In spite of the increase in the number of cases, the mortality remains almost same or marginally high, which is a great solace. And even our ICMR studies show that those who are vaccinated, definitely the severity of infection is less and the incidence of infection also is less. Regarding restrictions, COVID-appropriate behavior is given importance, and crowd management also has been given more importance. No more large-scale restrictions on movements are there, and travel restrictions, international travel, the quarantine does not exist now. So generally, things are getting relaxed, and helpline is there, particularly for those people with psychiatric or mental problems. And even in the budget, there is allocation for teleconsultation for people with psychiatric problem or tension and other things, which is being recognized as a major problem among the patients. And generally, now we are started to live with COVID, and hopefully we'll be able to control it further, and the plateauing may come to baseline. That's where we stand.
Thank you, Dr. Pillai. Can I invite Dr. Jamal from Bangladesh?
Hi, on the car. I'm sorry, actually. So, thank you so much. Actually, I just late actually because unfortunately I contracted COVID recently, and I have taken also this the drug, the Paxalivir. So it's good. It's good. We had actually 16,000 infections per day. Now it's surprising. The people are not actually following the SOPs, mostly not wearing masks, and the gatherings also government also just their gatherings and the ceremonies, but unfortunately, the people are not obeying those things actually much. And the government is not strict also. I don't know what is the policy behind. Government has ordered, but not monitoring those things actually. So regarding vaccination, it's also okay, it's going on continuously. And it has gone up more than 50%, full near 50% full doses, and more than 60%, the first dose. So this is a situation regarding vaccination, and regarding hospitalization, it's okay. It's all similar like India, and here also the less admissions, but still because the numbers are high, so the number of admissions also according to that number of infections are going on. So this is the situation. No, just only schools are closed. Schools are only closed. So everything is open. Thank you so much.
Thank you. Dr. Benito from Philippines.
Good afternoon from the Philippines. It's already 1:11. As of yesterday, we have a total number of new cases of 8,000 from the previous 35,000 in the first week. Then we have a declining numbers during the mid-January to first week of February. And we have a total of Total number of cases active, 151,000, comprising 4.2%. Then we have a total number of cases, 3.3 million, with total death of 54,214. Then as of February 4, the Philippines postponed its vaccination for 5 to 11 years old due to restraining order from different anti-vaxxer, and we will proceed with the launching of the national vaccination for 5 to 11 this Monday. We do hope that we can, our target population for 5 to 11 is 14 million. And we have a decreasing cases of cases in the National Capital Region, while there is still surge of cases in different provinces outside Manila. That's all.
Thank you, Dr. Benito. Can I invite Dr. Salma or Dr. Sajjad from Pakistan? Dr. Sajjad, are you there? Dr. Salma?
Good morning, everyone. I really enjoyed listening to you all. I have, before I go into the stats of Pakistan, can I ask a simple question? Are blood thinners still given? Like previously, till the Delta phase, in Pakistan, we used to give the blood thinners with steroids. Steroid was mentioned by Angelique, but what about the blood thinners in the rest of the world? Can anybody reply to this question, please?
If I can reply, again, experience Omicron, we don't give any blood thinners in primary healthcare except if they are admitted. We don't even give aspirin or that for the mild cases. There's the infection period is so short, and these people recover so quickly that there's actually we don't see any complications. This is now in South Africa setup. So no, we don't give.
Okay, thank you, Angelique. Now I come to Pakistan. In Pakistan, the Omicron is reasonably at a plateau at the moment for the last 3 days. It had reached about 8,000 new cases per day, but for the last 3 days, it's varying from 6,000 to 6,500. And the deaths are also the same. It varies between 30 to 40 deaths each day. But what is worrisome for us is that in spite of vaccination, like 8.4 crore have been fully vaccinated and 10.8 partially, with 2.7 lakh people having the booster dose. The mortality among children is high according to the papers, which was published by Al-Han University. It is 14% in children who have contracted COVID, which I think for our country is quite high. And I was very glad to learn that in the rest of the world, children are doing very, very well. So that is a bit worrisome. The rest, I hope we overcome it, but we can only overcome it if people practice safety. If they wear masks and they wash their hands. And somehow over here in our country, if you go to bazaars, you go to markets, you go anywhere, they've thrown caution to the wind. Very few people will be wearing masks and practicing it. So that is it from here. Thank you.
Okay. Surab, can I add something?
Please go ahead.
Okay, thank you very much, my worthy president, Dr. Salma Kundi. But before I add something, I just excuse that I joined late because I am in hospital. I became the grandfather yesterday evening, but my daughter-in-law went into the eclampsia, which is a very serious condition. She is in CCU now, but she is much better. So with good news of bad news also. So regarding the Pakistan situation, the situation is very good in Pakistan, but unfortunately, I have heard some of our participants said the SOPs is not following in other part of the world. Same in Pakistan. Everything is in normal, and I'm seeing people without mask. They are discussing with a close contact. There is no SOPs like things. So, but the situation is that the number of cases of Omicron or the coronavirus is decreasing. The percentage of positivity rate is decreasing. Although the test is not doing so much, but the positivity rate is doing. As I am an ENT practicing as an ENT surgeon in Karachi, I have been receiving these type of cases with the nasal symptom and throat symptom. I just want to know two things. That I have receiving patient with the symptom of Delta also. I asked the hair in infectious disease doctors. They said that this is not Delta, this is a Omicron symptom. So I just want to know the other people who is here, the participants of other countries. I have been receiving the cases with loss of smell, loss of taste, and which is the symptom of the Delta, and as well as some cases of diarrhea also. So particularly I request Anjali, because she said that there is no loss of taste or smell in her cases. So I have been receiving now, number one. Number two, why it is so, particularly for Monica, why it is so that the people are not following the SOPs, but the number of cases is going down. Why it is so? And also the number of vaccination is also going down. People are not interested in getting the booster dose or the basic dose. So in this scenario, what you say, what is this that the number is going down, and what to do as a activist, as a Pakistan Medical Association office bearer? What is our responsibility in this scenario? What we have to say the general public as well as the government, because the government is just imposing the ban and everything, but there is no implementation from the government side. So in this situation, kindly answer the two questions. Thank you very much.
Bob, can I come in?
Yes, Anjali. Thank you.
Thanks. Thank you so much for this question. So loss of smell, loss of taste is not Omicron. It can't be Omicron. They need to double check on the genome testing. We haven't seen it. Yes, the diarrhea, definitely that's the stomach thing, and that's what I think should be the BA.2. I think that's part of the Pango lineage. I think that's the only difference. But again, the diarrhea with the cortisone, I don't know why the cortisone is working. I don't know whether other people has got the same experience than we have, but it's self-limiting. What we have seen, if they've got severe cramps, we will give them a bit of Scopan Co tablets or Scopax Co just to try to alleviate that. But loss of smell and taste, not Omicron, definitely not. I have now again seen, I think my stats are now around about 200 because it's coming down. We don't see that much except for this last week again with the schools. But no, definitely not. the other very interesting thing that I have starting to see is because we keep very, very close monitoring of data. South Africa started with vaccination in May, June last year. So very interesting. If we test nearly every patient coming in testing, if it's between 1 and 5 days. So what we have noticed is that if vaccinated or had last year, up until September, you can test them. The chances that they are positive are quite high. Recently, I've now starting to see people being fully vaccinated up until October last year. So for me, it seems that the Omicron, maybe, because remember we haven't vaccinated before Delta, that the Omicron is escaping the immune system, whether you have had Delta before, whether you have Delta vaccinated, the whole story. For about 3 to 4 months, it seems to me that you are quite well protected, but thereafter you need to have a high index of suspicion. So we are now starting, October. My index of suspicion is then rising. It's very interesting. And I think there might be a genetically thing as well around this, because I have seen now quite a few patients coming back who had Omicron, who had been Delta, who had been vaccinated, but still get Omicron. So there must be something else as well than only vaccines and masks. There must be I call it genetically. Maybe Monica knows better about, can maybe explain this a bit better. But thanks. No loss of smell or taste. Definitely not.
Okay. Thank you very much. Thank you very much. But I just add something. What you are saying about the vaccine. Actually, at my home, my sons, his wife, my wife, all are infected recently, and they are now well. But I am safe. So I just, in my opinion, that I have a 2 booster dose Pfizer vaccine apart from the Sinopharm. So I just presume that this is because of my booster dose, or I am taking precautions. But at the same house, it's very difficult to protect yourself when everybody is in coronavirus. Isn't it? I'm thinking that. Is it true?
Well, what I have seen, sorry, Monica, that I jump in here. What I have seen for myself, I had been, and my surgery, my own personnel working with me, they've all been vaccinated. We're all with Johnson & Johnson. So far, I needed to go back for the booster. There was no time yet, and that's due to my own fault as well. But very interesting. I think none of us, and we work, as I've said, right through Delta up until now, but we use the normal precautionary measurements with mask wearing. We don't have protective clothes or anything. Also, don't get infected. Either we have build up immunity because of all our exposure to these patients, or there's something genetically. Don't know.
Yes. You're right. Yes, Monica, can you please?
Yeah, so I think that the answer to your question is complicated because I think there's a lot of factors that go into play. Well, factors include what is the virus status in the region that you're in? It's determined by the vaccination status of those in the localities. What are the vaccines that are available in the locality? What is the uptake? What is the approval of different age groups? It depends on the masking requirements in public places. I think that's why what you're seeing is a smorgasbord. You're seeing a variety of different outcomes. What we are hoping is happening is that when we achieve some level of community immunity or herd immunity, and we see the variations in these virus strains becoming potentially more infectious and as they become less dangerous, and as it becomes endemic versus pandemic, what we might now be seeing is that we're at a crossroads where we're starting to see the beginning of the end game of the pandemic. There are a lot of people who have tried to model when the pandemic will end. I know that those who have tried to model it are kind of taking a step back and saying, let's wait. But to develop SOPs that are used across the world internationally is, I don't think, the right way to approach it, because every community has its own needs of being able to implement things. So I think from a personal experience and from a community experience, you might have different goals. So if you have been infected, you might feel that, okay, I have some level of immunity in addition to my vaccine immunity. But wearing the mask, I sent a graphic about what the protection is with different levels of masking in the chat, especially from that study from California that was found on the MMWR. Showing that if you continue to wear a mask, then you will continue to be fine, irrespective of what the policies are. So there are some controls of what you can do on a personal level. I believe that when we are making decisions, that we're taking everybody's interest into consideration, and that we should be mindful of making sure that we follow whatever the guidance is. But if you want to add on that extra layer of protection for yourself, you can more than do that. I hope that answers your question.
Thank you.
Yes, comment from Taiwan, Dr. Yan.
Yes, go ahead.
Yeah, Taiwan has a very special experience to share. People usually think that the mild form of Omicron is because of the variant of the virus, and another factor is that effective vaccination and past natural infections, especially natural infections through Delta variants, has been probably play a major role in protecting from the severe diseases. But in Taiwan, because we had no major outbreak of the community, we had not experienced any of the major community outbreak before. So the natural infection in Taiwan is less than say 1 in 10,000. So I can see from Taiwan's view that the Omicron is really a mild form of infections, all right. But we must look out for its long-term consequences, like any kind of long COVID. However, like non-pharmaceutical intervention, like a mask and hand hygiene, as I emphasized, which is also very important in addition to the booster dose of vaccine. Yes.
Thanks, Dr. Yan, for the kind update. Dr. Akhtar?
Thank you, Saurabh. I just wanted to know, Dr. Kundi mentioned very high mortality in children. One of the articles she referred, is there other causes of death on the children, or is just a pure COVID-19 death increase in Pakistan? Dr.
I
Kundi?
don't know. I'll share the link of the article on this page right now. I think they'd only taken the COVID in consideration.
Because in South Africa, we don't have much death in children. It's a very, very few cases.
That's good.
Okay, so I think we have covered everyone. Yeah, so we have covered everyone. So anyone else left right now? Otherwise, we'll close the meeting. We are already over time. So thank you so much for joining in. This was 96th edition for National Medical Association International Weekly Meeting. With this note, we will end this session and see you again next week, same time, same day. Thank you.
Thank you. Thank you, everybody. Bye-bye.